by Dr. Karuna Garg ma'am, who is Director of Gynec Pathology, Cleveland Clinic and Professor at Lerner College of Medicine, USA. And the chairperson for today's lecture is Dr. Anita Burgess ma'am, Lab Director and Pathologist, Center of Oncopathology, Mumbai. Welcome you ma'am. The webinar is hosted by Dr. Sumit Gujral sir and Anita Burgess ma'am, and moderators for today's session are myself and Dr. Pooja Gajaria. A few reminders regarding connection interruption and poll questions. A few disclaimers. Few more disclaimers. The upcoming seminars on 12th September is by Dr. Anita Burgess ma'am on the topic Understanding the Non-Neoplastic Endometrium, and on 17th September by Dr. Santosh Menon sir on ovarian neoplasms. Let's start. I request Karuna ma'am to start sharing her screen, please.
Opportunity. Give me 1 minute. Entire screen. Share. Okay, can you see my screen now?
Very well.
Yes, yes, ma'am.
Okay, excellent. So thank you again for this opportunity. I'm really happy to be here, and I'm going to try to take you through some diagnostic issues with gestational trophoblastic disease. So as you know, gestational trophoblastic disease comes in various flavors. So we have the molar pregnancies, which include partial and complete moles, as well as rare cases of invasive moles. There are tumor-like lesions, and then there are true gestational trophoblastic neoplasms, including the most common, which is choriocarcinoma. Then there are others like epithelioid trophoblastic tumor and placental site trophoblastic tumor. So this is going to be the outline of my talk. We'll do some general concepts first, then go into molar pregnancy, followed by the gestational trophoblastic neoplasms, and then we'll cover the neoplastic-like lesions in the diagnostic challenges area. So let's start with general concepts. So as you know, trophoblastic cells come in three forms. You have the cytotrophoblasts, syncytial trophoblasts, and the intermediate trophoblasts. And the intermediate trophoblasts are further divided into implantation site and chorionic type intermediate trophoblasts. And it's nice to get this clear in your head because each type of intermediate trophoblast will give rise to a particular type of benign entity and a particular type of tumor. So it's nice to get this sorted because then it becomes much easier to think about the immunohistochemical staining pattern and so forth. So this is a schematic showing the different types of trophoblasts. I mean, we're all familiar with the multinucleated syncytial trophoblastic cells and the mononuclear small cytotrophoblasts. And then again, the intermediate trophoblasts come in two flavors. So this is the implantation site intermediate trophoblasts, which as the name implies, lie in the implantation site. And then the other ones are the chorionic type intermediate trophoblasts, which are in the chorion levae and the membranes.
Karuna, can I interrupt you for a minute?
Of course.
Can you make your cursor into a laser pointer, please? Do you know how to do that? Just,
I
right
don't.
click.
Do you?
That's right.
Okay. And then what? And then pointer option.
Yes.
This is amazing.
So
I didn't know
can
this.
be seen. No, when
Thank
you move your cursor now, it's sorry about that. It's
No. Thank you. I appreciate it. So this is better. Okay. All right. So we'll keep going.
Yes. Thank you.
Okay. So again, these are the types of trophoblastic cells, and here I've listed the cytologic features of each. Again, the syncytial trophoblastic cells are the only ones with multiple nuclei. The others are mononuclear cells. The cytotrophoblasts are easier to recognize because they are small and they have, a small amount of cytoplasm as well. The implantation site trophoblasts are the ones that are bigger cells but are mononuclear. And this is the best immunohistochemical marker if you're trying to, sort out these type of trophoblastic cells. So implantation site intermediate trophoblasts stain for HPL or human placental lactogen, and chorionic type intermediate trophoblasts stain for P63. And this becomes important when you're talking about the different neoplasms that arise from these two types of intermediate trophoblasts. Syncytial trophoblasts will, of course, be positive for HCG. So this is what implantation site intermediate trophoblasts look like. So when you get a products of conception type of case and you see the implantation site, those are the intermediate trophoblasts that will stain, and these are the ones that will stain for HPL. These are the chorionic type intermediate trophoblasts that lie within the chorion levae, and these will be positive for P63. If you did an HPL, there would be some staining, but it would not be diffuse. So when you think about gestational trophoblastic neoplasms, this is how you think about them. So choriocarcinoma is a mixture of syncytial trophoblasts, cytotrophoblasts, and it also has some intermediate trophoblasts mixed in there. When you think about the other gestational trophoblastic neoplasms, they arise from the intermediate trophoblastic cells. So the placental site trophoblastic tumor, or PSTT, arises from the implantation site intermediate trophoblasts, and these are positive for HPL. The epithelioid trophoblastic tumor, or ETT, arises from chorionic type intermediate trophoblasts, and these are P63 positive. And these are the benign counterparts. So when you think about implantation site, IT, the benign counterpart is exaggerated placental site. The malignant counterpart is PSTT. In chorionic type intermediate trophoblasts, the benign counterpart is placental site nodule. The malignant counterpart is ETT. And again, if you get this sorted in your mind, then it makes it much easier when you look at these tumors. In terms of immunohistochemistry, the pan-trophoblastic markers, remember these will be positive for all sorts of cytokeratins. So it's not going to help you if you're trying to distinguish between a trophoblastic neoplasm and a carcinoma. So these will be positive for keratin, for EMA. They will be positive for inhibin. This is supposed to be a pretty specific trophoblastic stain, but we don't have it. I think the only institution that has these stains is Johns Hopkins. So I have no real experience with these. Also remember that GATA3, which is positive in urothelial and breast tumors, is also positive in trophoblastic tumors. So it will stain the mononuclear cell. So it's often pretty diffusely positive in trophoblastic neoplasm. So something to keep in mind. SAL4, which is a germ cell marker, is also positive in cytotrophoblasts. It does not stain syncytial trophoblasts or intermediate trophoblasts, but if you took a choriocarcinoma, you would get a lot of staining for SAL4 in the cytotrophoblastic cells. This is a schematic of the immunohistochemistry. I'll leave that for you guys to look at later. We're not going to go into those details right now again. So let's go on and talk about molar pregnancy and abnormal villus morphology. This is something that you're likely to come across your desk pretty often. So starting with complete hydatidiform mole, this of course occurs in first or early second trimester, and most patients will have large for gestation uterine size. They may have a lot of preeclampsia or symptoms of hyperemesis. And their beta-HCG is often markedly elevated, much higher than you would expect for that stage of pregnancy. The ultrasound has this typical snowstorm appearance that's very characteristic for a complete mole. And when you look at the genomic makeup of a complete mole, it's basically diploid, but both the sets of chromosomes are from the father. So it's diandric diploid, and this is very important. And this can either be from a single sperm that multiplies, and this is the majority of the cases, or it can be two different sperms, which is the heterozygous variety, which is a minority of complete moles. There are rare cases of familial biparental complete mole that are caused by mutations in these genes, NLRP7 and KHDC3L. These are pretty rare. I have actually not seen a case myself. The importance of recognizing a complete mole is that it does carry a risk of persistent gestational trophoblastic disease. It's actually pretty high. It's 15 to 20%. The risk for choriocarcinoma is 2 to 3%. And this risk seems to be higher in complete moles that are dispermic or heterozygous, so the minority of these cases. So this is, of course, characteristic gross appearance of a complete mole. We rarely see them like this anymore because, you know, most cases are now, at least in the US, detected at early stages. So it's rare to see this gross appearance. But if you do, then you can be fairly certain you're dealing with a complete mole. And then this is that snowstorm appearance that I was referring to on ultrasound, which is very characteristic of a complete mole. In terms of growth, again, if you see them late enough, you're going to see those voluminous enlarged hytropic villi. By definition, you should not see any fetal tissue in a complete mole. The only exception that I'll remind you of is we have seen cases of twin gestations in which you have one normal gestation and one complete mole, in which case you may see some fetal tissue. So keep that in mind. In terms of microscopic appearance, you know, if you see a complete mole, most descriptions that you'll see in a textbook are later gestation. So you'll see enlarged hydropic villi, you'll see cisterns, there'll be prominent circumferential trophoblast proliferation. Very characteristic feature is this karyorectic debris that you'll see in the villus mesenchyme. And again, you should not see fetal tissue unless you have a twin pregnancy. So these are examples of complete mole that we've had over here. You can see there are markedly abnormal villi. This one has a huge trophoblastic inclusion in the center, which is not at all normal. And you can see other villi are also very abnormal, enlarged and very irregular contours. Here you have another example. The villi are enlarged. There are multiple trophoblastic inclusions. In this particular villus alone, we have about 4 or 5 trophoblastic inclusions, and they are very large trophoblastic inclusions. That's pretty suggestive of a molar pregnancy. Again, notice there's a lot of trophoblastic proliferation around these villi. Normal villi will have polar trophoblastic proliferation. So you'll see trophoblasts at both poles, but here you can see it's circumferential, and that's pretty abnormal. Same thing here, you get this trophoblast proliferation all around this villus. That's abnormal. Again, notice the villi are very large and they have this myxoid kind of stroma. Here you can see a cistern in the middle as well. So pretty suspicious right away when you look at something like this. Another example of a cistern. So there's this empty space in the middle of the villus. When you see this, it's pretty strongly suggestive of a molar pregnancy. You can see it in both complete and partial mole, but unlikely to see it in a non-molar gestation. This particular case had a lot of trophoblastic proliferation. You can see there's proliferation all around this villus, and the trophoblastic proliferation has this lace-like appearance. So you see these little lacunae. That's also very suspicious for a molar pregnancy. Same thing over here, you get that lace-like appearance that you're seeing over here, and the trophoblast cells look atypical. And then finally, you see this karyorectic debris in the villus stromal cells. When you see this, it's very suspicious for a complete mole. Even partial moles usually don't show karyorectic debris or as much karyorectic debris as you see here. How do you go about proving that you have a complete hydatidiform form mole? I mean, if you're very suspicious and very confident and the clinical picture adds up, you could sign it out. Here in the US, we almost always prove it by doing a P57 stain. So P57 is a gene product of a paternally imprinted but maternally expressed gene. So basically what you need to take away is if there is no maternal DNA, the P57 is going to not be expressed. That's the bottom line here. So a complete mole should have no or very little P57 staining in the villus mesenchyme and the cytotrophoblasts. And also remember that P57 is not going to help you if you're dealing with a partial mole or a non-molar abnormal villus morphology. So the only role P57 has is in the diagnosis of a complete mole, because that's the only one that does not have any maternal DNA. So here's an example of a complete mole in which there's no staining for P57. Again, remember you're looking for P57 staining in these stromal cells in the villi as well as the cytotrophoblasts. You will see P57 staining in intermediate trophoblastic cells. You will see it in the background decidua. If you're not seeing it, you should repeat your stain because that means your stain is not working well. Here's another example of the case I showed you. The villous stromal cells as well as the cytotrophoblasts are completely negative for P57, but your background intermediate trophoblastic cells and decidua is positive. You can see some P57 staining. So for example, in this case, when you look carefully at your villous stromal cells, there is some staining for P57, and this much staining is okay. You can still accept this if your case otherwise looks good for a complete mole. So they say up to 10% is acceptable. It's usually weak staining like this. It's usually patchy. And if my case is otherwise good for a complete mole, I feel pretty confident that this is a negative P57. Moving on to partial moles. In this, your beta HCG is normal or only mildly elevated. Partial moles are, of course, triploid. And in this case, 2 of the chromosomal sets are from the father and 1 is from the mother. So it's diandric triploid. More than 95% of partial moles come from 2 sperms, so it's a dispermic partial mole. There's a small minority in which the paternal chromosomal set gets reduplicated, and that's a monospermic partial mole. Notice that the risk for persistent gestational trophoblastic disease for partial mole is substantially lower compared to the complete mole. So in the complete mole, it was 25 to 30%. Here it's 0.5 to 5%. And your risk for choriocarcinoma is less than 0.5%. So really, the downside of missing a partial mole is not bad at all. In fact, I've heard some people say that it doesn't matter if you miss a partial mole. We still try to diagnose it if we see it, but you really don't want to miss a complete mole. So in terms of gross features of a partial mole, it's usually normal. You may see focal hydropic changes, but it's not going to be that dramatic gross appearance that you see with a complete mole. In terms of microscopic features, this is the characteristic feature that you'll see described in books, that you see 2 distinctive villous populations. You'll see small fibrotic villi and then a population of the enlarged irregular villi. This is, I'm not sure that I see this in every single case, and I feel like I see some non-molar gestations that also have variation. But if you see this, it should make you think about a partial mole. The enlarged villi of a partial mole will have some similarity with what you saw with a complete mole. It's just not going to be as dramatic. So it's going to be less enlarged. You'll have fewer inclusions. You'll have less trophoblast proliferation. And the other thing that you frequently see with a partial mole is you may see nucleated red blood cells. When I'm looking at an abnormal villus morphology and I see nucleated red blood cells, I can pretty confidently say this is probably not a complete mole, although there are rare cases of complete moles that can have nucleated red cells. But if you're seeing nucleated red cells and abnormal villus morphology, that you may be dealing with a partial mole. The other thing about partial moles is that there's a lot of morphologic overlap with non-molar abnormal villus morphology. So with trisomies and so forth, we'll talk more about that in a minute. So here's an example of partial moles that we've had here. You can see this one has small fibrotic villi and a population of larger abnormal villi with a lot of irregular contours. Another example with the small fibrotic villi and a population of larger villi. Once you look at the larger villi, there is some overlap with both a complete mole as well as a non-molar gestation, but this one does have quite a lot of trophoblastic proliferation. And there was occasional cisterns. This is a case that we had recently, which went for genotyping and was proved to be a dispermic partial mole. So again, notice this one has a lot of nucleated red blood cells. And when you see that, you know right away that it's probably not a complete mole, because that means there was fetal tissue present. Otherwise, there would be no nucleated red blood cells. And then you start to see these enlarged villi with a lot of irregular contours. You see trophoblastic inclusions, often multiple, often large. And again, you can see trophoblastic proliferation around these villi as well. It's just not going to be as dramatic as a complete mole. And then again, you see the nucleated red blood cells and you know you're probably not dealing with a complete mole. Another example with trophoblastic proliferation, irregular contours, and nucleated red blood cells. So remember, P57 is not going to help you in the diagnosis of a partial mole because there is one copy of maternal DNA, so it's going to have retained staining. You can send it for ploidy, and in the old days, if it came back triploid, we used to call them partial moles. Turns out that's not really accurate because a triploid with two maternal copies of the DNA, so a digynic triploid is not a molar pregnancy. So a partial mole is defined as diandric triploid. So a triploidy enough is not sufficient for a definitive diagnosis of partial mole. So really for us, definitive diagnosis of a partial mole requires genotyping. And let's talk briefly about genotyping. I don't know if you have genotyping available in India or not. Do you? It just becomes more pertinent.
I don't think it's being done for moles.
It's not being done? You're doing it for maybe fingerprinting and so on, right?
Yeah, that's right.
Okay. So it's basically the same test that you would do for forensics or for fingerprinting. I'll just go through it quickly because it's very interesting. But basically you're using these short tandem repeats, which are repetitive DNA sequences that are highly polymorphic in the population. So here what they are doing is they are basically taking DNA from the mom's tissue, so the decidua, and the villus tissue, which is the fetal tissue, and then you're comparing the patterns of each. And then you're trying to decide whether the alleles in the villus tissue, do they match with the decidua, which means they are maternal, or do they not match, which means they are non-maternal, and which means they are probably coming from dad. That's basically the gist of genotyping. So it's a really interesting way to look at these cases. So I'll just show you like some schematics just out of interest. So you basically take the decidua, which is mom, you take the villi, which is fetus, and then you compare the alleles on both. So here you can see that one copy of the, let's see, this is a non-molar specimen. So you can see one copy of the villi matches with one copy of the decidua. So one copy is coming from mom. There are only two peaks, so it's diploid. One copy is from mom. One copy doesn't match mom, and you can assume it's coming from dad. So this is biparental diploid. It's normal, non-molar, one copy from mom, one copy from dad, diploid gestation. So this is a non-molar study. In contrast, this is a complete mole, and you can see here that you have two copies, so it's diploid in the villi, but none of the copies match mom, right? Look at the mom's alleles and look at the baby's alleles. None of them are matching, so you can assume both of these are coming from the father. So it becomes diandric diploid, which is what defines a complete mole. Please stop me if it doesn't make sense, but that's basically the gist of it. And then this is what a partial mole will do. In this case, you are going to say that there are only two peaks here, but notice that one peak is double this. So it's triploid. There are two copies in here. And so this is triploid and only one matches mom. So you know that it's triploid and one copy is from mom, so two copies are from dad. So this is diandric triploid, which is what defines a partial mole. So does that make sense? So anytime we are worried about, yes, okay, anytime we are worried about a partial mole, this is what we do. We don't do it here. We send it out to Yale, which is where this study is done, and we get a result back and report it as a partial mole or a non-molar gestation. There are rare cases of molar pregnancy that invade the myometrium or lymphovascular spaces, and these are referred to as invasive mole. We had a case recently like this. This was a complete mole, and the villi had invaded into the myometrium. We were even worried about LVI, although we couldn't really prove it in this case. But you can see there are villi diving down into the myometrium over here. So this was a case of a complete mole that was invasive. Same thing over here. There were villi. We were wondering if this is a vascular space, so I signed it out as suspicious for vascular invasion. So let's go on to non-molar abnormal villus morphology. So you can get abnormal villus morphology that is not due to a molar pregnancy. And of course, you're going to want to try to separate the moles from the non-moles. And these are often due to chromosomal or genetic abnormalities. So trisomies is probably the most common cause of abnormal villus morphology that's not accountable due to a molar pregnancy. We talked about this digynic triploid. So this triploid in which two copies are coming from mom. These are non-molar, but they can also result in abnormal villus morphology. And then placental mesenchymal dysplasia can also result in AVM. So of course, when you get this, your differential diagnosis is often a partial mole. And the only way to really resolve that is to send the case for DNA genotyping. So these are examples of non-molar abnormal villus morphology. You can see the villi are enlarged, they are hydropic. You can see trophoblastic inclusions. You can even see areas of trophoblastic proliferation. So it's going to look like a mole for all the world when you look at it under the microscope. And the P57 will of course be retained because this is not a complete mole. So this is the algorithmic approach when you're dealing with a possible mole. So if you're worried about a possible mole, the first thing we do over here is a P57. If the P57 is negative and the morphology is appropriate, we just sign it out as a complete mole. We don't send it for genotyping. If your P57 is positive, then we do molecular genotyping. If it comes back diandric triploid, it's a partial mole. If it's biparental diploid, it's a non-molar pregnancy at that stage. What do we do in real life? If we have a differential diagnosis of partial mole versus non-molar, if the morphology to us is very suspicious, we send it for genotyping. If the morphology is, like you're not really sure, then we report it as abnormal villus morphology, and we say in a comment that we can send it for genotyping if the clinician wants us to. And if the morphology is not very concerning at all, we sign it out as abnormal villus morphology and say we suspect it's not a mole. If your case has gone for cytogenetics, it may be better to wait, because if it comes back triploid, then you know it might be a partial mole, and then we would send it for genotyping. Bottom line is clinical implications of a missed partial mole is likely not significant, although we really don't want to miss it unless, given a choice. So any questions on the molar pregnancy and abnormal villus morphology? No, can we keep going? Okay, so let's move on
Yes,
to
ma'am,
gestational.
Actually, there
Okay,
are
there are
few
questions.
questions in the chat box.
Okay.
Yeah. Do normal villi have nucleated RBCs?
Yes, you can see nucleated red blood cells in normal villi as well. It just tells you that fetal organs were formed, basically. The reason complete moles don't have them is because the fetal organs and liver and wherever the hematopoiesis occurs early hasn't formed, so there is no potential for having nucleated reds.
Yeah, so the next question is where to look for NRBCs. So that is
within the villus mesenchyme. That's where you're going to see them.
Yeah.
So yeah.
Then please explain morphology of fibrotic villus.
So fibrotic villi will be small villi where normally when you see the villus stromal cells, they are spread out, they are hypocellular, they're small cells, there's a lot of empty space. With fibrotic villi, that will be obliterated and there'll be fibrosis within the villi. Basically, that's the gist of it. Yeah.
Yeah, then there are other questions asking for differentiation of partial hydatid mole from abortus, hydropic abortus. So I think
that's the one that I was trying to address early.
Yes.
So again, if you're seeing a lot of morphologic features, that's how we handle it here. I understand you may not have genotyping available. So then if I don't have genotyping available, and I'm not seeing, all I'm seeing is hydropic change, no trophoblast proliferation, no inclusions, none of the other features, then I would sign it out and I say I favor this is not a molar pregnancy. The other way to handle this is in reality to say that you cannot exclude a mole if you are worried, and they can monitor the beta HCG for these patients, and they can see, make sure it's going down properly, and then they can be pretty reassured that it's probably not a molar pregnancy.
Okay.
Karuna, there's
Yeah.
a very interesting question.
Uh-huh.
It says, why is the intermediate trophoblast
Yes.
positive? Yeah, I think that's a very interesting question.
Excellent question. When I first started dealing with P57, that was my first question too. It makes no sense. So I went in and did some more digging into this. I'm not a molecular pathologist, but what I understand is that and I'll quote from the paper that I read this from, that the imprinting gets loosened in the intermediate trophoblastic cells. Please don't ask me what that means because I don't have any idea what that means, but that's what I read. Something about intermediate trophoblasts, that imprinting gets loosened and they are able to express P57. I agree with you that logically they should not express P57, but there's something in that process where intermediate trophoblasts lose that imprinting and they can actually express it. But yeah, really good question, because that was the first question I asked too. Like, that doesn't make any sense. So yeah.
I think you can carry on.
All right.
Thanks.
Let's go on to the neoplasms, gestational trophoblastic neoplasms. Again, we sort of went over this, so we're going to start with choriocarcinoma. So this is, of course, the most common and the most aggressive gestational neoplasm. Most patients will present with abnormal vaginal bleeding. We have seen cases where the diagnosis is due at the time of metastasis. So the tumor's already gone to the lungs or the liver or the brain. So that does happen. Usually choriocarcinomas will develop within 2 years of a preceding pregnancy, but they can occur later. In more than half of the cases, the preceding gestation is a molar pregnancy, a complete mole in most cases. There are rare cases in which choriocarcinomas have been linked to partial moles, but in most cases it's complete mole. Some of them are non-molar, so there are some abortions, there are some normal pregnancies, and even some ectopic pregnancies with choriocarcinoma. In terms of growth, these will present with a hemorrhagic necrotic mass. This is a case we had in which this was a choriocarcinoma, and you can see there's a huge necrotic, really ugly looking mass in the uterine cavity. This was another case we had in which this was in the lower uterine segment area, and it was much more subtle, but you can see how hemorrhagic it looks. In terms of microscopic, I think we're all familiar with what a chorio looks like. You're going to see a lot of hemorrhage, a lot of necrosis. If you're thinking of a choriocarcinoma and there's not a lot of hemorrhage and not a lot of necrosis, you're probably not dealing with a chorio. There's going to be a lot of mitoses and of course this biphasic cell population, which is very characteristic. So it's going to be those mononuclear cells, which are cytotrophoblasts and intermediate trophoblasts, and then the syncytial trophoblasts, which can be very flattened and attenuated, and they tend to wrap around the mononuclear cells. Remember, you should not see chorionic villi if you're thinking of a choriocarcinoma. The only exception, and I'll say this multiple times, the only exception is you can get rare cases of intraplacental choriocarcinoma, but remember, those will be detected at term. So you're grossing a placenta or you're looking at a placenta and you see a hemorrhagic mass and you take sections of that and it's a choriocarcinoma. That's how you find those cases. You're not going to see them in the first or second trimester. So if you're thinking of a first or second trimester case, or there's no pregnancy, there's no term pregnancy, you're probably, you should not see chorionic villi if it's a choriocarcinoma. So this is characteristic of choriocarcinoma. At low power, you're going to see a lot of hemorrhage, you're going to see a lot of blood, and then you start to see these plump cells and these flat multinucleated cells, and you can already start thinking maybe this is a trophoblastic tumor. Again, on higher magnification, a lot of blood, a lot of necrosis, and then you start to see these large cells. Again, that lace-like appearance can be very helpful, and these multinucleated cells that are sort of wrapped at the periphery. Keep going, and again, that same appearance. You see these mononuclear cells, which is a mixture of cytotrophoblasts and intermediate trophoblasts, and then outside it, you see these syncytiotrophoblasts with that very dense cytoplasm and multiple nuclei. So this biphasic appearance, hemorrhage, necrosis, you're almost sure just by morphology that this is a choriocarcinoma. Again, sometimes this is what your syncytiotrophoblasts will look like. They just become flattened and you can't really identify them as such because they get stretched out. But again, this is that biphasic appearance with the multinucleated and the mononuclear cells. Same thing here. These are your syncytiotrophoblasts that have become stretched out. They have this purplish cytoplasm that can also help you recognize them. And very brisk mitotic activity. If you did a MIB, it would be more than 90% in these cases. Same thing here. This really shows that biphasic appearance very nicely. You have those mononuclear cells, and then at the periphery, you have those syncytiotrophoblasts that are getting stretched out and flattened out. Same thing again, highlighting those syncytiotrophoblasts at the periphery. You can get monophasic choriocarcinomas in which your syncytiotrophoblasts are not very prominent. I think the context where I've seen this described is patients who may have been treated, so they may have got some methotrexate, and then you tend to see this more often. I haven't seen one that's all monophasic like this, so. In terms of immunohistochemistry, these will be positive for keratin. These will have a high proliferation index, and they will be positive for HCG. If you do intermediate trophoblastic stains like HPL and P63, there will be scattered positive cells as well. So this is a keratin strong diffuse staining in all trophoblastic tumors, basically. HCG will be positive, HPL will show a few cells that are positive, and again, the MIB1 will be very high. In terms of clinical outcome, they can metastasize to many sites, but the good news is that choriocarcinomas are exquisitely sensitive to chemotherapy. So your survival rates are actually really good. They're close to 100%. You can get occasional death from disease, and that's often if there's extensive bleeding in the brain or the lungs. And then HCG can be really helpful to monitor the course of this tumor. Moving on to PSTT or placental site trophoblastic tumor. Again, remember, placental site trophoblastic tumor comes from implantation site intermediate trophoblasts that are positive for HPL. So these patients will either present with bleeding or with uterine enlargement. 60 to 70% of these cases will actually follow an uneventful term pregnancy. 20 to 30% will follow either a complete mole or an abortion. The time from previous pregnancy can be very variable. It can go all the way from 1 week to 204 months. The median is 12 to 18 months. And there's actually some literature suggesting that the longer the time period from the prior pregnancy, the worse the outcome is for a PSTT. In choriocarcinomas, the serum HCG is sky high. That's not true for PSTT. It's usually only slightly to moderately elevated, and most cases will be confined to the uterus or stage 1 at the time of diagnosis. PSTT will almost always have a tumor mass. Not every single time, but more than 90% of cases should have a distinct mass in the uterus. This is what it looks like under the microscope. So you can see there's a mass-like lesion that's infiltrating into the myometrium. That's very characteristic of a PSTT. The most notable feature for a PSTT is how it invades the myometrium. So you can see it's destroying the myometrial fibers. It's forming this large mass-like lesions between the myometrial fibers. And this is very important because this is how you distinguish it from its benign counterpart. So again, mass forming, you get sheets of these implantation site intermediate trophoblasts. You want to see them pushing those muscle fibers apart. You will see mitoses, and you can also see vascular invasion in PSTT. So again, this is what your cells will look like. They are mononuclear cells, abundant cytoplasm, pretty atypical. They can form cords and nests. You can see mitoses. You can see occasional multinucleated cells, so that doesn't exclude this diagnosis. And again, this is very characteristic. You can see them splaying the muscle fibers apart and forming these mass-like lesions between the muscle fibers. This is really what you want to see to make a definitive diagnosis of PSTT. And again, the desmin really highlights that pushing the muscle fibers apart. You can see vascular invasion, but remember, you can see vascular invasion in a normal implantation site as well. In terms of immunohistochemistry, again, it's going to be positive for all your cytokeratins, inhibin. This will be positive for HPL. Even we don't have an HPL stain here, so I have no experience with it, but this is what you use. If you do a MIB1, it will be 10 to 20% of the cells should light up with a MIB1. So again, HPL, there will be some HCG. It won't be like a choriocarcinoma. Cytokeratins will be positive. And if you do a P63, it's mostly negative. MIB1, again, you will see some proliferation. So about 10 to 20% is the number that's out there. In terms of clinical outcome, this is really important because it's very different from a choriocarcinoma, which responds really well to chemotherapy. PSTD does not respond to chemotherapy. So your primary treatment is actually surgical, so these patients will have a hysterectomy. 10 to 15% of these are actually, unfortunately, clinically malignant. And HCG is low, but you can still use it to monitor the course of the disease. So things that have been associated with unfavorable outcome, if there's already high stage disease at presentation, if your mitotic index is high, if the tumor is large and there's clear cells, but I think this is the most important one, if your preceding pregnancy was more than 2 years ago, that actually has been shown to really correlate with worse clinical outcomes. And I actually don't know the reason for that. Moving on to the next one, which is ETT or epithelioid trophoblastic tumor. Again, these arise from your chorionic type intermediate trophoblast. So these are P63 positive. So these patients will present with amenorrhea or abnormal bleeding. They can be misdiagnosed as ectopic. Some of these patients can actually present with extrauterine tumor in lung or other sites. Like PSTT, most of these follow a normal delivery. A smaller subset will follow a molar pregnancy or an abortion. And like PSTT, the time from previous pregnancy can be quite variable. And like PSTT, the HCG levels in ETT are also low level elevation. A majority of these are actually located in the upper endocervix or the lower uterine segment. And again, a small minority of them will actually be extrauterine at the time of diagnosis. These should also show a discrete mass in the endometrium or the lower uterine segment. Sometimes they can be polypoid and they're associated with hemorrhage and necrosis. Here's a case that I think I got this picture from one of my colleagues, but this is the cervix, and this was an ETT sitting in the upper cervix, lower uterine segment region. In terms of microscopic, ETTs are pretty characteristic looking. They have this nodular appearance, they're well circumscribed, they'll have a lot of necrosis associated with it, and you get these mononuclear cells with this eosinophilic material associated with it. Another thing that you frequently see is this lymphoplasmacytic cell infiltrate at the periphery, and they can have a lot of calcifications as well. So this is very characteristic of an ETT. You get these nodules, almost granuloma-like nodules. Of course, these are not granulomas, but they could make you think about them on low power. You get this central comedonecrosis and then these mononuclear cells. Also notice all these plasma cells and lymphocytes at the periphery, which is very characteristic. It's not specific, but it can be helpful. A lot of necrosis with these sheets of viable cells in the middle, and again, necrosis in the middle of that as well. This is what the cells look like, mononuclear, atypical, but fairly uniform. Same thing here, you can see occasional multinucleated cells, you get mitotic activity. And sometimes they can almost start looking squamoid. You know, you can, one of the differentials for ETT is a squamous cell carcinoma or even H cell. I'll show you an example of that later. In terms of immunohistochemistry, again, these will be positive for your pan-trophoblastic markers, and remember, this will be positive for P63. And like PSTT, your MIB1 index will be about 10 to 20%. So P63 should really light up this tumor. If you do an HPL, occasional cells will be positive, also with HCG, and inhibin will be patchy positive. Cytokeratin will be diffusely positive, and MIB1 should be about 10 to 20%. So like PSTT, ETT does not respond well to chemo, so your primary treatment is surgical. Most of these will have benign outcome, but about 25% will have metastatic disease, and 10% of these patients actually will die of disease. And like PSTT, your HCG is low, but it can be used to monitor the patient. And like PSTT, most of these patients actually do not respond well to chemotherapy, unfortunately. I'm not going to talk about FIGO classification for GTN. It's out there, but there's a way of mapping risk for each of these that the clinicians use when they're trying to decide how to treat these patients, just so you're aware that this is out there. So let's go on to diagnostic challenges. So I think I've divided them into 3 different categories. Is this trophoblastic proliferation neoplastic? If it is, what kind of neoplasm? And then finally, when you have a tumor, how do you decide if it's actually of trophoblastic origin? So let's start with scenario number 1. You have a 35-year-old woman. She undergoes an uterine aspiration at 8 weeks, and this is what you get. So you get this very exuberant proliferation of trophoblastic cells. You have these mononuclear trophoblastic cells. You have the syncytial trophoblastic cells. You have some hemorrhage, not a lot. Same thing over here, this biphasic appearance. You're looking at this by itself. Could start thinking this is a choriocarcinoma, right? It looks like it. I think the only thing that I would say is there's not as much hemorrhage and not as much necrosis as I would expect in a choriocarcinoma. So that's going to be your differential. You start looking around and you see villi, right? What does that do? That immediately takes choriocarcinoma out of the running. So you look at these villi, they also look abnormal. They are enlarged, they are irregular. You start to see trophoblastic proliferation around many of these villi. Same thing here, you're starting to see some cisterns. Notice that this villus has trophoblasts all around it, which is highly abnormal. And you do a P57, your villus stromal cells as well as your cytotrophoblasts are negative for P57. So you know you're dealing with a complete mole. So the message here is that the diagnosis is a complete mole. You can see a very, very exuberant trophoblastic proliferation when you have a molar pregnancy. And again, the basic message for this case is if you see chorionic villi, in general, that excludes a diagnosis of choriocarcinoma. Again, the exception is intraplacental choriocarcinoma at term pregnancy, which is a very different clinical scenario. So this is a line I've lifted from a textbook, but basically what it's telling you is that if you see villi, basically in the first or second trimester placenta, you know you're not dealing with a choriocarcinoma. You can see the trophoblastic proliferation in these cases can be very, very exuberant, very atypical, and it could really make you think of a choriocarcinoma, but I would pull back if I see villi in this scenario. Again, the exception is this one that I was referring to. This was a term placenta we had. You can see the mature chorionic villi. And in the middle of it, there was a mass that was noted grossly, and sections from that show an intraplacental choriocarcinoma. But obviously, this is a very different context. Same thing here. This is that case of intraplacental choriocarcinoma. So again, remember, complete moles can have a lot of trophoblastic proliferation. So if you're seeing villi, that trophoblastic proliferation is probably just the trophoblast proliferation that you see with a molar pregnancy. Second scenario, you have a 35-year-old woman with bleeding. She undergoes a curettage. you again see this trophoblast proliferation, right? See these intermediate trophoblastic cells, mononuclear cells. You can see them invading blood vessels. There's fibrin in the vessel wall. You could start thinking, could this be a trophoblastic neoplasm? You could even see them going through the myometrium like this, not destroying, but percolating through the myometrial fibers, which could start making you think that you're dealing with a trophoblastic tumor. You do an HPL, it's positive, telling you that this is implantation site trophoblasts. So are you dealing with a PSTT? That becomes your question. Again, look around. You see villi, right? I see 2 villi, maybe 4 villi in this particular slide over here. Again, the basic message here is you see villi, it's not a trophoblastic neoplasm. So this now becomes an exaggerated implantation site, which remember was the benign counterpart of PSTT. So here's your implantation, exaggerated implantation site, which is the benign counterpart of PSTT, also arising from implantation site intermediate trophoblasts. So what is an exaggerated implantation site? It's basically a benign expansion of a normal placental site. You tend to see it most often with a molar pregnancy. So if you're seeing an implantation site that looks very exuberant, very atypical, the thing I do in that context is I look at my villi really carefully to make sure I'm not dealing with a molar pregnancy. Not all of them are associated with moles, but the vast majority are. So again, this degree of atypia, just the exuberance of this proliferation could start making you think of a neoplasm. So again, exaggerated implantation site. Remember, your implantation site trophoblast will normally invade the myometrium, right? So this is normal. We get consults like this, like, oh, this is invading the myometrium. Does that mean it's a tumor? It's not. What you want to see for tumor is, remember what I showed you, where it's splaying the myometrial fibers and forming large masses. Although something like this would scare me too, I'll be honest with you. I would show it to my colleagues and also maybe do a MIB one. But this is what exaggerated placental site can look like. And this is exaggerated implantation site in a complete mole can look even more scary. So this is an example we had. Again, because you see villi, you can back off. But if you didn't, you would be really worried that this is actually some sort of gestational trophoblastic neoplasm. And again, these will be positive for cytokeratin, they'll be positive for HPL, but if you do a Ki67, it's basically 0. Like there should be almost no staining in any of these cells for a MIB1. So that can be very helpful in the differential. So again, this is how you distinguish between PSTT and exaggerated placental site. PSTT is almost always mass forming. Exaggerated placental site is a microscopic finding, no mass. You should not see chorionic villi in a PSTT, and the MIB1 should be high in a PSTT and basically 0 in an exaggerated placental site. Okay, moving on to the third scenario. You have a 50-year-old who undergoes an endometrial and endocervical curettage for vaginal bleeding. The endocervical curettage has this finding. So you're seeing these little nodules of these atypical cells with this hyalinized eosinophilic material. You go on higher magnification, you see these trophoblastic cells again within this hyalinized material. You see some inflammatory cells. You do a P63, it's positive. It tells you that this is chorionic type intermediate trophoblast. So you start thinking, could this now be an ETT, right? But this is actually a placental site nodule. So again, placental site nodule is the benign counterpart of ETT, also derived from chorionic type intermediate trophoblasts, and it's P63 positive. This is basically nothing but benign retained placental site tissue. So it's implantation site that hasn't completely gone away and it just stays around. Often you see it, in our experience, it's almost always an incidental finding. Sometimes it causes bleeding and you may see it in that context. Remember, you can see a placental site nodule many, many, many years after a pregnancy. So it could be like 20 years later or something like that. These are small, they are well circumscribed, they have a lot of eosinophilic material, and you get these single cells or small groups of cells, no mitoses, and you can see inflammation. So this is very characteristic of a placental site nodule. You get these nodular things with a lot of eosinophilic material and these trophoblastic cells. Another example, you can have variable amount of cellularity in these. We'll talk more about atypical placental site nodules in a minute, but this is what a placental site nodule will look like. If you stained it, it would be positive for keratin and P63. If you do a MIB1, I find MIB1 to be very challenging in these cases because there's a lot of inflammation. So you have to be really careful when you're looking at a MIB1 in these to make sure you're not counting your inflammatory cells when you're doing a MIB1 index. It should be extremely low in a placental site nodule. This is a table showing the difference between ETT and placental site nodule. I'll leave this here for you, but Ki67 can be helpful. Size, necrosis, cellularity, all of those things will play a role. Again, highlighting the difference between an ETT and a placental site nodule. I do want to talk briefly about this entity of atypical placental site nodule. As the name implies, this shows features that are intermediate between a placental site nodule and an epithelioid trophoblastic tumor. So, the problem is this is a very vague diagnosis. We struggle with this a lot as well because there are a number of criteria that have been put out: size, cellularity, cohesion, cytologic atypia, necrosis, infiltrative margin, and higher Ki67 index. So, this is a very ill-defined entity, and I think it's very subjective. In this study, about 14% of cases of atypical placental site nodules either had a malignant trophoblastic disease or developed one within 16 months of diagnosis. Bottom line is, something like this, which is so cellular, it's not enough for me to call this an ETT, but it's worrisome, right? This is more than a typical placental site nodule. I think something like this I would call an atypical placental site nodule. I'm not seeing mitotic activity, but the degree of cellularity is pretty amazing. When I see something like this, when there's so much of it, and you see multiple nodules, it has these long plaque-like lesions with variable cellularity, I would probably flag this as atypical as well. The other thing that has been put out is when you get these cohesions, so you start to get these cohesive nests, but they are not enough for a diagnosis of ETT, and there's more atypia. I would call something like this atypical placental site nodule, but you can imagine how subjective this diagnosis is. So when we diagnose atypical placental site nodule, I basically say in a comment that some of these can be associated with gestational trophoblastic neoplasia. So make sure the patient does not have a mass lesion. Maybe do a repeat curettage to make sure it's all out, and then follow the beta-HCG. If there is a mass lesion, then they should probably consider doing a hysterectomy at that point. That's how we handle these in real life. All right, I think we're already at an hour. Should we stop here, Dr. Borges? Dr. Sumit?
I think it's continue.
Please continue.
Continue. Okay, this is I think I have very little left. So the next scenario is what kind of trophoblastic neoplasm. So, I've just put a table here for ETT versus PSTT. The growth pattern of ETT, like I said before, is nodular and circumscribed. PSTT tends to be infiltrative. You can see vascular invasion in both. You can do immunohistochemistry. HPL will be diffusely positive in PSTT. We don't have HPL either, so we just do a P63. If it's diffusely positive, that would favor an epithelioid trophoblastic tumor. Is there a clinical implication to distinguishing between them? I don't think there is. So I don't think it matters if you call an ETT a PSTT or vice versa. But these are the things you can use to distinguish between these entities. Again, these are just microscopic images. Again, PSTT, I think the most characteristic thing about PSTT is the way it invades into the myometrium, which you usually do not see with an ETT. ETT and PSTT versus choriocarcinoma. I think the biggest is choriocarcinomas are usually biphasic and have those syncytial trophoblasts. If you do HPL and P63, there'll be focal staining for both, but the Ki67 in a choriocarcinoma is way higher than you would have in either ETT or PSTT. The last scenario is this actually a trophoblastic tumor? So let's talk about trophoblastic tumors versus carcinoma. So I had mentioned this briefly before. Epithelioid trophoblastic tumors, as I mentioned earlier, can often be present in the cervix or lower uterine segment. I have seen at least a couple of cases of ETT that colonize the surface of the cervix and can even start looking like HSIL. So there's a lot of morphologic and immunophenotypic overlap between ETT and squamous lesions. So here's an example. If you can believe me, this is an ETT that actually went up and colonized the cervical, the surface. If you got this on a biopsy, I mean, I think most of us would call that HSIL. But there were other areas that where it declared itself as an ETT. Again, there's one here that's colonizing the surface of the cervix. And I showed you this picture before, but if you took this and put this in the cervix, my first thought would have actually been, is this a squamous cell carcinoma rather than an ETT? So a lot of overlap between them. This is what you can use if you're ever struggling with that diagnosis. Again, remember, both will be positive for cytokeratins. Both will be positive for P63 and P40. I think what we use in this scenario is P16, which almost all squamous lesions of the cervix are associated with high-risk HPV, so they'll be P16 positive. ETT is not P16 positive. The Ki67 of a squamous cell carcinoma is higher. GATA3 will be diffusely positive in an ETT. There will be weak staining for GATA3 in a squamous cell carcinoma. And then if you have a high-risk HPV in situ hybridization, and if it's positive, that will really clinch it as being a squamous lesion of the cervix. Also remember that trophoblastic tumors can present in extrauterine sites. You know, in the lung, I've seen ETT present in the lung for the first time. I've seen ETTs present in the abdomen for the first time without there being a uterine lesion. How does this occur? You know, the abdomen, most of these patients will have had a history of a C-section, right? So they had a C-section, there was a molar pregnancy or even a non-molar pregnancy, but some of the villi got left behind, or products of conception got left behind, that then grew into a trophoblastic tumor. With the lung, you know, the speculation is you can see vascular invasion with a molar pregnancy, for instance, and let's say it metastasized to the lung, it sat there, and then it grew into the tumor there. So those are just speculations as to how this occurs. But this was a very interesting case I had in real life. It was a 50-year-old woman. She had an abdominal tumor. You know, this was worked up like crazy. It was positive for keratins, for EMA, and diffusely positive for GATA3. So based on that GATA3 staining, it was signed out as poorly differentiated carcinoma, and they said it's probably urothelial. So based on that, she undergoes a cystoscopy, and there's nothing in the bladder. They do a bladder biopsy, they do a urine cytology, nothing at all there. So nothing is really making any sense. This is what the tumor looked like. So this is in the abdominal wall. There were sheets of these mononuclear atypical cells associated with a lot of necrosis. You know, poorly differentiated carcinoma is what we would all be thinking, right? I think I've shown images of this before, so you can guess, I think, where this is going. So no urothelial abnormalities, negative urine. What was the diagnosis? So we started thinking, could this actually be a trophoblastic tumor? And we sent it for genotyping. And the results of the genotyping were consistent with the trophoblastic tumor. So what they found was that there was an allele in the tumor that didn't match the allele, the STRs of the patient. So they knew it was coming from somewhere else, and you could speculate that it's coming from dad. So it's a paternal allele, which basically proves that it's a gestational trophoblastic neoplasm. So this actually turned out to be a malignant trophoblastic tumor that I signed out, and I said it had features of an epithelioid trophoblastic tumor. So this was a really interesting case. And this is another setting where genotyping can help you out. Genotyping can help you if you're thinking of whether something is coming from a teratoma. It can help you out when you're thinking of a trophoblastic tumor outside of the uterus. It can help you out, of course, in the diagnosis of a partial mole as well. So there's a paper, you can read this if it's interesting to you, but extrauterine ETT presenting as primary lung carcinoma. So it does weird things like that sometimes. So keep that in mind. When should you consider this possibility? If it's a young woman, if it's an epithelioid tumor that's positive for all the epithelial markers, it's positive for inhibin, it's diffusely positive for GATA3, but there's no other primary sites. There's nothing in the breast, there's nothing in the urothelial tract, then this should come to you at that point, like, could this be a trophoblastic tumor? And if you're thinking about it, send it for genotyping. I know you don't have a formal genotyping test, but you could send it for fingerprinting, like they use for forensics, although the interpreter has to know what they are looking for in this case. So remember also that carcinomas from any site can show trophoblastic differentiation. So you can get elevated HCG as a result. I've heard of patients who have colon cancer and are coming in for surgery. They're young, so the day before the surgery, they do a pregnancy test just to be sure, and the pregnancy test comes back positive, and they think the patient is in fact pregnant. They're not. It's the colon cancer that has trophoblastic differentiation, and it's secreting HCG, which is being picked up by the pregnancy test. So, keep that in mind. This is a uterine mass from a 48-year-old. It looks like an endometrioid carcinoma. There was areas of undifferentiated carcinoma. And then finally, there were areas that looked like choriocarcinoma in this case. And if you did an HCG, this would be positive. And if you did a serum HCG, it would be high in these cases as well. So again, if you put this out of context, you would say this is a choriocarcinoma. But in this case, this is a carcinoma with trophoblastic or choriocarcinomatous differentiation. So when you have a trophoblast proliferation, basically look for chorionic villi. If there are villi, you're probably not dealing with a neoplasm. And that's when I would start looking for features of a molar pregnancy. If the villi are absent, is it forming a mass? If it is, it's probably neoplastic. If it's biphasic, it's probably a choriocarcinoma. Look for those other features. If it's mononuclear, it's either a PSTT or an ETT, and these are the features you can use to distinguish between those possibilities. And these are my references, and I'll stop here, and I'm happy to take any questions, although I think we're over an hour, so thank you.
Thank you so much, Karuna. This was really a very interesting talk, and a lot of people are interested in it because, curettage and finding what we call products of conception are not uncommon when we on your surgical pathology table. And I can see from the number of questions that there are in the chat box, particularly from somebody called Gayatri. Obviously, Gayatri is seeing a lot of. Can you stop sharing your screen, please?
Sure. Yeah.
Yeah. Yeah, that's right. Okay. And
Okay.
Gayatri seems to be really haunted by trophoblastic disease because she's asked a number of questions. But
Okay.
I think it was very, very lucid, the whole talk. And I think you should take the questions now, and maybe the moderators will take the questions. But let me just ask one of the questions that Gayatri has asked, and that is, she's worried, because choriocarcinoma seems to have all three components. It has the biphasic trophoblast in the sense there is cyto, there is in situ, and also intermediate trophoblast. She asks, what is a mixed trophoblastic tumor?
Yeah, I find that entity very subjective and elusive myself. But, I think so the scenario where I think true mixed trophoblastic tumors exist is, let's say you have a choriocarcinoma and you treat that patient. That's when So I don't know if you go back, I don't have that paper on hand with me, but Dr. Kerman has a really interesting paper on this, where he talks about the plasticity of trophoblastic cells and how they can go from one to the other. So he talks about cytotrophoblasts being able to move to intermediate trophoblasts, being able to go to syncytial trophoblasts, and vice versa. So I think what happens is you have a choriocarcinoma and the patient has been treated, but the tumor is not fully resolved and you happen to see the tumor at that point. I think the idea is that some of those cells have matured one way or the other. So you start to see this mixed picture of trophoblastic tumors. And that's when I think the true mixed trophoblastic tumors occur. Have I seen one myself? I have not. I have not made that diagnosis. But I will tell you, I have seen plenty of intermediate trophoblastic tumors where I go from one field to the next and I'm like, oh, this looks like an ETT. And then, no, this looks like a PSTT. You know, so that scenario I've definitely seen. And in those cases, sometimes we just call them intermediate trophoblastic neoplasm or malignant intermediate trophoblastic neoplasm, see comment, and then say it has features of both. The choriocarcinoma mixture, I think, happens once chorio has been treated. That's my limited experience with mixed trophoblastic tumors.
Yes, Karuna, I've never made the diagnosis of a mixed trophoblastic tumor. I think it's more in the imagination than that really exists. I can't remember seeing Dr. Kerman's paper, but I feel when you have an intimate mixture of cyto as well as in situ and intermediate trophoblast, because that's what Gayatri is asking. Please, I don't think that it should be called a mixed trophoblastic tumor.
No, I don't think so.
It's a standard, sort of choriocarcinoma. I take your point that once it's been treated, you may get the evolution of a placental side trophoblastic tumor. I don't know. I've never seen one, but I feel that if you do see a choriocarcinoma and a very separate mass that might have a placental side trophoblastic tumor, maybe then that justifies your calling it not an intimate mixture of the two. But I think that may be the answer to Gayatri's question. And then there was another interesting question, and then I will leave it to the moderators to ask the rest of the question. But one of these was how to make a diagnosis of an invasive mole. Do you require the hysterectomy to make that diagnosis?
Yeah, the only time I have diagnosed invasive moles, and I've diagnosed two, I think, in my career, both were in hysterectomy specimens. You know, unless your clinician is doing such an aggressive, I would still not feel comfortable. I think the only time I would diagnose it is if it's in a hysterectomy specimen. I suppose if you could see LVI, like true unequivocal LVI in a curettage, which is also highly unlikely. But if you do, then maybe that's a scenario, but that's theoretical. I've never diagnosed it like that. Yeah.
Yeah, I agree with you. I think, that we, just like normal pregnancies can have an accreta, increta, percreta, it happens with hydatidiform moles. You can, the molar pregnancy and its villi, as well as the intermediate trophoblast, can go right through the uterine wall. So you can have a molar pregnancy with an accreta placentation.
Absolutely, yeah.
Yes, you can have a molar pregnancy with an increta placentation, and you can have one with a accreta placentation. And the only way you can really figure it out is that these patients are bleeding and bleeding, no matter what you, the curettage. And the beta HCG is not coming down. So that brings me to my next question. And then I'm sorry, Pooja, you'll have to just wait to ask the questions in the chat box.
Yep.
Do you really think that it matters all that much whether we spend a lot of time trying to distinguish a complete mole from a partial mole or from hydropic pregnancies, because now we're getting these evacuations very early at 7 weeks, at 8 weeks. And very, very early, not in the second trimester, for which most of the criteria for the diagnosis or the differential diagnoses were concerned. Now, do we really need to do this, or will the clinicians in any case follow these patients up with beta HCG and treat them if there is a plateau, if the beta HCG doesn't come down? So where is the real role for pathologist in the diagnosis of these early diseases, molar diseases? I'm not talking about PSTT or ETT.
Yeah, no, I completely agree with you. We struggle with this too. I think there is a argument to be made for finding a complete mole. And I think the reason is that, the risk for gestational trophoblastic disease is high. So here, the implication is, let's say I make a diagnosis of a complete mole. The clinician tells the patient, you cannot get pregnant for a year. And basically what that does is it allows them to follow the beta HCG. If she gets pregnant, the beta HCG goes up, it's a mess, right? Like,
yes.
So I think that would be the only reason, I would say, to diagnose it, so that they can follow the beta HCG appropriately, and the patient knows there's a risk for gestational trophoblastic neoplasia. Everything else, the partial mole, I agree with you. I think we overdo it, and I acknowledge it. And we used to send a lot of these for genotyping, like every case. We've stopped doing that. Our clinicians have asked us to stop doing that because the patients end up with these bills of, so significant amount, and it has no clinical implications. So now in most cases, unless the clinician calls me and says, please send this for genotyping, we sign them out as abnormal villus morphology and say we can't completely exclude a partial mole, and we leave it to them. You're absolutely right. And in most countries around the world, this is the US where we overdo everything, as you know, but in most countries around the world, nobody is routinely genotyping partial moles, so
yeah, I agree. And I think that, the earlier on now that we're getting all these evacuations, sometimes I feel that even trying to make a diagnosis of a complete mole is also an issue. And then you have to be transparent with your clinician and say that they better follow this up with beta HCG and give the appropriate advice about not getting pregnant to the patient. And this is
perfect.
true because I see that Gayatri is really, really, obsessing about trophoblastic disease, because she asked an interesting question, and that is, the earlier you evacuate these pregnancies, the more trophoblastic quote unquote proliferation you see, because early pregnancies just show you a huge amount of, before it settles down to the polar syncytial knots or whatever that you see. It's tough, that you may mistake trophoblastic proliferation, at least normal trophoblast, for trophoblastic proliferation. So Gayatri, please don't obsess about it. That's what I'm telling you.
Gayatri, you should know that we all struggle with this. At my previous institution, we had we used to have consensus meetings, and we had a printout of a crow on the wall, and every time we would get these moles wrong, your name would go on that. And I can tell you that experienced pathologists with like more than 20 years of experience would say, I am positive this is a complete mole, and it would not be. So I think we all are very humbled by these, but also know that the clinical put everything together and then decide how much to obsess over it at that point, and make your clinician aware if you're worried, I think, is the main thing, like Dr. Borges said.
Yeah, I agree with you, Karuna. And trophoblast is hard, but you just get used to it, and common sense and context is very important, I think.
Correct.
Yes, come on. I'm sorry, Pooja, but please go ahead with the questions.
Yeah. On limited material of curating or endometrial biopsy, can you please explain how to definitely distinguish PSTT and choriocarcinoma, since the management changes and HPL-IHC is not available in many centers?
I mean, I think again, the choriocarcinomas will have a lot of hemorrhage, will have a lot of necrosis, will have that characteristic biphasic appearance, which you're not going to see in a PSTT. I can tell you that nobody can confidently diagnose a PST. I shouldn't say nobody, but I think in most cases, you cannot confidently diagnose a PSTT in a curettage material. You really cannot. You can raise an alarm for it, but really you want to see invasion, you want to see a mass lesion in the uterus. I think a choriocarcinoma, when you have a true chorio, will not be scant. You'll have abundant material, you'll have a lot of necrosis and blood, and then that biphasic appearance. If you're still struggling, a MIB1 can help you out as well, because it's going to be very high in a chorio.
Yeah, I think what Karuna is saying is that if you see a syncytial trophoblast, it is not a PSTT. You would never see syncytial trophoblast in a PSTT, so look for it. And the syncytial trophoblast, and you saw some lovely pictures that Karuna was showing, have this kind of fishnet cytoplasm. You know, you've got lots of vacuoles in the cytoplasm. It's not just the multinucleation. Sometimes, you know, that's a little bit difficult to see because they all clump together. But you see this fishnet. It's literally like holes in the cytoplasm connected by these thin little cytoplasmic connections, you know. So I think you see that, and no, it's not a PSTT. But you see that, and it may be a carcinoma. It's not.
That's right. That's right.
Because you can see that kind of trophoblastic differentiation in a standard carcinoma. So you have to be very, very careful. And you get this thing in the cervix, ETT in the cervix, and you do a P63. And I've seen it n number of times. And I'm sure anybody who sits in a place where, like a funnel, you know, you get this reviews and so on. Oh, the number of times that a squamous carcinoma has been diagnosed and it is something else, you know, or somebody's calling this a trophoblastic disease and it's a carcinoma. So it's just something that one gets. You just have to remember. That's it. Okay. Any other questions, Pooja, please?
Yes, ma'am. Do beta HCG levels help to differentiate choriocarcinoma from CHM with exuberant trophoblastic proliferation?
I don't think you can use that confidently. Both will be pretty high, I think. Right, Dr. Borges? Is that your thought as well?
Sorry, I was distracted. What was the question?
Do beta HCG levels help to differentiate choriocarcinoma from complete hydratiform mole with exuberant trophoblastic proliferation?
No, I don't think so. But you just have to follow the beta HCG. If the beta HCG is falling, it cannot be a choriocarcinoma.
Right, without treatment. Yep.
Yeah.
Is there any defined time frame from time of miscarriage or curating after which we report EPS and not just normal implantation site, like normal involution site?
No, I don't think it's time. It's defined by time. It's defined by the characteristics, like how exuberant it is, how atypical it is. Again, there's some degree of subjectivity in that diagnosis. I think it doesn't matter if you don't call something an exaggerated placental site. The main thing is to not call it a PSTT. That's the basic message. Yeah.
So some of the participants have asked to show the images again, but I think they can go through the recording.
That's right. I mean, it's going to be up till Sunday, so please go and look at the images again, including the algorithm, which was, I think, very helpful.
Yes. One last question that has popped up. Does ETT and PTT treatment differ? Why do I have to differentiate this for the clinician?
Yeah, no, that's what I was saying, that ETT versus PSTT doesn't really matter in terms of management. Both require surgery. I don't think there is really a clinical significance to that distinction, to be honest with you. So, yeah.
That's all in the chat box.
All right. Good. So I thank you very much, Karuna. You probably had to get into work earlier than you normally do to.
No, it's all good. Thank you so much for this. Yeah, thank you for this opportunity. Yeah.
And we hope to see you more often on the